we are really happy to have with us Dr. Tanuj Dada, and he's a professor of ophthalmology and heads the glaucoma services at RP Center for Ophthalmic Sciences, All India Institute, and have been always lucky during my ARC times to have a solid support from him. And we look forward to learning from him a very important topic, techniques for augmented trabeculectomy. On to you, Dr. Tanuj.
Thank you very much, Dr. Chitra, for your very kind information. So, good evening, everyone. Can you see my slides?
Yes, we can.
Okay. So, I think whatever the advancements in glaucoma surgery, trabeculectomy still remains the gold standard. The only issue regarding glaucoma surgery is that it's a paradox because you are injuring the eye. If the eye heals, you get scarring and bleb failure. On the other hand, if you use a lot of antimitotics, then you end up with hypotony and infections. So I think the critical issue is how to augment your trabeculectomy success and modulate wound healing so that you can improve success and reduce complications. Now, the long-term outcomes of trabeculectomy have been very impressive. And if you see this nearly a decade of follow-up, if you see trabeculectomy with mitomycin C, so you can see nearly 75% of patients achieve target IOP of less than 18. So this is nearly 10 years after surgery. So these sort of outcomes are not possible with any other surgery till date in glaucoma. The important thing is that mitomycin C dosage is 0.2 milligram per ml, and that is quite an appropriate dosage for 2 minutes. If you increase this dose to 0.4, then there's a higher risk of complications. So this is a very nice message that with 0.2 milligram ml for 2 minutes subconjunctival, very good long-term success and very less incidence of the side-setting eye complications. Now the question for today is how to improve success of trabeculectomy and how to enhance your trabeculectomy. So I think the most important thing is to have a checklist, and what I do is to just push the lid over the superior conjunctiva and see if it is mobile or no. So this is a very simple test you can do in the OPD. And it's very important that we are doing so many patient surgery and they come from far off. And you must look at the ocular adnexa for all these risk factors, especially blepharitis and meibomitis, and look for conditions which are high risk for filtration failure like ocular surface disease and any form of conjunctival scarring, and diabetes also a risk factor for increased risk of failure of trabeculectomy. So before you jump into any surgery, this is very important that you rule out any ocular adnexal problems and ocular surface problem. Otherwise, you will not get a good result even if you do a very good surgery. Now, what I have learned over the years is that when patients come to us, they are already on 4 to 5 medications, and there is a subconjunctival inflammation which has to be taken care of. So, if you have a patient with high pressure and you have to do a trabeculectomy, it is very important that you prescribe preoperative steroids, fluoromethalone, at least 1 to 2 weeks prior to surgery. Although there is a risk of a spike in IOP, you should cover the patient with oral acetazolamide and don't operate until the conjunctiva is quiet, because then you will get, if you operate without steroids, you will get a very proliferative fibrotic response. Your trabeculectomy will fail. In fact, some of these patients, especially younger patients, are even start patient preoperatively on systemic steroids so that the healing response is less. And this is very well known in literature that trabeculectomy success with and without preoperative steroid, there is significant difference. So fluoromethalone reverses the subconjunctival inflammation, and it is mandatory before you subject any patient to trabeculectomy. So in their study, it was 4 weeks, but that may be a longer time. So even 1 to 2 weeks prior to surgery, you should start steroids. Now coming to the technique, there are several techniques and all of them are very good. So I'll just show you a two, three important points which you must remember. Whenever you're doing a trabeculectomy and you want to save surgery, you must see these three landmarks: the white scleral tissue, followed by this bluish tinge of the limbus, and then the clear cornea. So whenever you're doing trabeculectomy, it is always better to make your incision into the clear cornea and enter the anterior chamber. If you make an incision posteriorly, there is higher risk of hemorrhagic complication, injuring the ciliary body, and even getting vitreous loss. So that must be kept in mind. So I always put a preoperative pre-place sutures, put in air in the AC, and then enter into the air bubble and then make a ostium. So this is the basic tenets of doing a trabeculectomy surgery. The most important thing is to do a incision into the clear cornea. And other important things, because we get a lot of patients who are high risk, one-eyed patients, 5-degree field, and there is very risk of the vision loss during trabeculectomy. So in some of these patients, especially if there is a hemangioma, you can use an anterior chamber maintainer and always use some form of releasable and adjustable suture so that the post-operative hypotony is not there, because that is a harbinger of complications such as suprachoroidal hemorrhage. So try to have preoperative, intraoperative, and postoperative pressure as the same. And that can be achieved with preoperative mannitol and intraoperative surgery, so that you always have pre-placed suture in place and use of releasable or adjustable sutures. And for high-risk cases, I also inject some sodium hyaluronate at the end of surgery, because that keeps the AC formed and you don't get a sudden swelling of the AC, especially younger patients who may rub the eye. It's important to give a Cortera shield to these patients. So this is one of the patients in which there is a Sturge Weber. So in these patients, it's also better to give a preoperative 1 week of systemic beta blockers that decreases the hemorrhagic complications of these patients, and to have the intraoperative tamponade. So I have put in the AC maintainer. So when you are entering the eye, your infusion is on. So that prevents the sudden hypotony. And then you can also titrate the amount of aqueous, the filtration from your ostium, because these are the patients where there is very high risk of intraoperative choroidal hemorrhage. Now, this is a new technique that we started in RP Center, and that is the creation of an intrascleral lake. So this is known as a augmented trabeculectomy. And in this, we make a regular trabeculectomy flap, which is 50% of thickness. And then what we do is we create a deep colectomy pocket. So you have a regular flap and then you have this pocket created. So this is 90% depth. So what this does is that there is a intrascleral lake always present. So that decreases the fibrosis between these two flaps. The rest of the surgery continues as is, but you will see the aqueous draining and pooling into this lake here. So that augments the success of trabeculectomy. And what we found was that by using this deep sclerectomy, you are augmenting the drainage through 3 pathways. Of course, the first one remains subconjunctival space, but in addition, there is an intrascleral root drainage. And also, if you're deep enough, you also get subchoroidal drainage. So that enhances the success. And this was the study published, the effect of limited deep sclerectomy. And we found definitely that the success rates were much higher when we augmented a normal trabeculectomy with this limited deep sclerectomy. And the main difference is that in non-penetrating deep sclerectomy, you go up to the limbus and deroofs the Schlemm's canal, but that takes a lot of time and has inherent complications. So we just stop short of the limbus so that this pocket is created, and you can see this very nice intrascleral lake is there. This prevents the fibrosis between the flaps in the sclera and also helps to have a long-term better IOP outcomes, as you can see from this study. Now, this was a new idea because sometimes, you get patients who have got a dense scarring and the patient cannot afford a glaucoma drainage device. So in this surgery, what we did was that the first part of surgery is same, that you do a limited deep sclerectomy. But in the second part of surgery, what we did was that we cut it down up to the ciliary body. We introduced a small cyclodialysis cleft. And then what we did was this part of the scleral tissue which is available to us, we made a sort of roll of this and inserted it into the cyclodialysis cleft as a stent. So that what happens when you create cyclodialysis, due to inflammation, it closes down. So by using the patient's own scleral tissue, we created a small cyclodialysis cleft, so you can have a subconjunctival drainage, but because of the fibrosis, you also have a drainage through the cyclodialysis cleft. So this was a new technique that is combining the trabeculectomy with a limited deep sclerectomy and also cyclodialysis and using the patient's scleral tissue as a graft. So this is only for very limited cases where you have dense scarring and you want to have cyclodialysis. So this technique is just an innovation. It requires further validation with studies from other surgeons, but it's a good thing to have in your armamentarium, and you just create a 1 clock hour of cyclodialysis. Now, there is a lot of interest in anti-VEGF agents. So the common question asked is that should we augment trabeculectomy with anti-VEGF agents? And the answer is a big no, as you can see from this meta-analysis. If you combine anti-VEGF agents with trabeculectomy versus a mitomycin C, so there is no benefit of combining an anti-metabolite because it has a short-term effect. This is only useful if there is a rubeosis iridis or you are using it for neovascular glaucoma. For a routine trabeculectomy, mitomycin C should be used to prevent fibrosis. Anti-VEGFs are not useful for in this regard, and the long-term outcomes are not useful. The other thing was we also had for some time this implant available, Ologen implant, and this was advocated as a replacement to trabeculectomy to augment it. But histopath studies showed that there is a dense fibrosis within the implant, so it is not at all useful. And in fact, we tried to use it in addition to mitomycin C, and you can see the type of blebs we used to get a ring of steel around the ologen. So we have stopped using these ologen implants. So in my opinion, there is no benefit of adding these collagen implants to trabeculectomy, even if you are using mitomycin C. So mitomycin C trabeculectomy remains the gold standard. The next important question is that often there is a confusion. Patients are referred to you who have got both a cataract as well as they have got glaucoma. So should we do your trabeculectomy before or after the phacoemulsification? So this is a common issue, and I think there should be very clarity on this. The sequence of trab followed by phaco is not a good option. You should do phaco first and trab afterwards. That is because when you do phacoemulsification, there is an increased inflammation and your trabeculectomy bleb fails. So cataract surgery has the tendency to compromise IOP even when you have a temporal phaco and a superior bleb. So if you see the cataract, it reduces the bleb function due to upregulation of the fibrogenic cytokines and increase in the conjunctival fibroblasts. So they found that the sequence, if you do trab first, followed by phaco, that has worse outcomes as compared to doing a phaco first, followed by trab. So ideally, if you have both the diseases, you do the phacoemulsification, wait for at least 6 months to 1 year so that the blood aqueous barrier is healed, and then subsequently you do a trabeculectomy, which is much easier in a pseudophakic eye. And another thing which is very important, you have done a very good trabeculectomy and patient comes back with high IOP, and that is because we have this tendency to stop steroids at an early stage. And that is something you should never do. The post-operative steroid on a tapering should continue at least 3 months after trabeculectomy surgery, and you should taper it off. And if you find that there is vascularization of the bleb occurring, then even you can augment systemic steroids, because this is the main reason why your trabeculectomy fails if you are not monitoring the post-operative healing response of the patient. And finally, I think why you are scared of trabeculectomy is this complication that you will end up with blebitis and endophthalmitis. So it's very important to counsel the patient about the risk and the symptoms of this complication. And if any time in the post-operative period you detect a bleb leak or patient develop blepharitis or is using any form of dry eye therapy, you must counsel the patient about the risk. And if you detect any bleb leak, immediately that has to be repaired to decrease the blebitis and endophthalmitis. And we have found success in early bleb leaks with the use of doxycycline. So this is a conservative therapy that can be used in the early post-operative period to manage bleb leaks without doing any surgical intervention. And just finally, one small tip about trabectectomy, that when you make a trabectectomy flap, so this we are all used to. So the main thing I have learned over the years is never cut it to the limbus. So you can see what the, so trabectectomy flap has been made, but only 50% has been cut, so that on both sides this tissue remains. And I think that is a very important factor, that this and this side is not cut. That prevents the post-operative shallowing and leak from this area. So this is a very important thing. Never cut the trabeculectomy flap up to the limbus. So I think that is all I wanted to cover. Thank you very much for your kind attention.
Thank you so much, Dr. Tanuj. I don't know about others, but I'm definitely going to hear this talk all over again because such lovely, lovely tips you give, so practical and so easy and relevant. But talking about that deep small punch of scleral tissue which you remove from the scleral bed, would you keep it only for special cases, or do you believe it should be done in all routine cases?
See, actually, if you are dealing with juvenile glaucoma or young patient, the sclera is very thin, then this is not possible. But if you're dealing with cases which are advanced, which have got uh, like a field defect less than 10 degree, or where you require low target IOP, then this technique is very useful. So 50% you make an initial depth and then you make a small crater. So we have been using it for a lot of our cases because we get referral of advanced cases. So as a routine, we have been using, and it gives a very good long-term outcome. The only thing is there is a risk of overfiltration. So the edges of this deep colectomy should not overlap with the flap. It has to be narrower. If it overlaps, then it causes overfiltration. And what we do at the end of surgery, we apply trypan blue and see if there is any area of excess, that and you have to apply an extra suture. Otherwise, it's a very good technique for increasing outcomes. And trabeculectomy is a one-time surgery, So this modification increases long-term success without reducing the complications.
Oh, thanks a lot. Dr. Sunita, wanted to ask you, and I'm sure I would want Dr. Tanuj's thoughts on that too. What are your thoughts about using injection mitomycin versus sponges? Like people who are using sponges should give up on it, or both of them are nearly parallel in their long-term outcomes?
So, there are several studies which suggest that using injection in long run is more beneficial because you're using a more titrated dose. And also the bleb form is more diffuse. Unless you ensure that you use sponges very posteriorly, so as to form a very diffuse bleb. But there are studies which also suggest that the amount of mitomycin C delivered with the sponges vary a lot. Like if you use 0.2 milligram per ml, so the concentration of the MMC which is delivered ranges from 0.7 to 17 micrograms. So there is a large variation of the dose delivered. But still, despite knowing that, I've been using sponges only in my trabeculectomy, and I'm getting good results. So although theoretically injectable MMC is better because you can titrate better, but practically I found not much difference between the two. But when I'm doing needling, I use injectable 0.1 milligram per ml. So theoretically, there are papers which suggest it is good, but I don't think we have long-term data, Indian data, to suggest that.
Dr. Tanuj, Dr. Pandav, and Dr. Gauri, just two lines for your thoughts on this.
I agree with Dr. Sunita. Like the injectable, there is also this limitation that you need to give the injection, wait half an hour, and then proceed with the surgery. So there is this logistics also, which you need to factor in. You can also standardize the amount that you deliver by keeping your vexel sponge pieces of a uniform size. and keeping, say, always standardize saying 4 swabs I'm going to keep in posteriorly. So your own method, you can standardize it. It will not be down to the micron level the same, but at least it will not be too variable. Dr. Tanuj, I wanted to ask you more about that cyclodialysis that you were talking about. So we all know that cyclodialysis, when we do it or when it inadvertently happens in a trauma, the eye pressures tend to come very low, and suddenly at some point of time the cleft closes and the pressure shoots up. Okay, so there is this degree of unpredictability which is associated with cyclodialysis. What is your experience with regarding to this when you have used this to augment the trabeculectomy as you showed in your talk?
So first thing is, this is not for general viewer. So
Okay.
it's only for very specialized glaucoma surgeons. So this is just an innovation side. Like you have this MIGS, you have all these new implants coming, which are inserted between the ciliary body and sclera. So they function by causing a localized cyclodialysis.
Yes.
So what we found was this is only very limited when there is dense scarring like post-vitectomy cases.
Okay.
So we make a 1 clock hour cyclodialysis. But what we found was it used to close down definitely due to fibrosis. So there we use this small scleral tissue, patient's own sclera, as a sort of stent so that the cyclodialysis does not close. So it functioned well, but we have hardly done, I think, 4 to 5 patients over the last 10 years. So I think it's a technique which requires further innovation and exploration. It is definitely one of the tenants available, and I think this the route of this cyclodialysis must be explored, because now we are getting lot of glaucoma drainage devices which are being placed in the ciliary body.
Suprachoroidal space, yes.
Yeah, so I think this is something we have not explored.
True, true.
So I just wanted to introduce this concept, but at this moment, I don't think anybody should take it down into the operation theater. It will require further refinement.
Yeah. Thank you, Dr. Tanuj.
Dr. Morley, any questions? Murli, you're muted. Unmute yourself.
So, would you say there is a continued role for 5-fluorouracil in the postoperative period, especially when the bleb is angry looking, or would you rather give mitomycin injections or drops?
No, Murli, I think there is definitely role of 5-fluorouracil, and if you get a encysted bleb or an angry looking bleb, then you can inject 5-fluorouracil, and always you have to take care that you are coating the cornea with viscoelastic, so that if it doesn't touch the cornea, that causes a very toxic epitheliopathy. But definitely, if you have early scarring, then 5-fluorouracil can be used. If you have late postoperative, very dense scarring with more risk factors, then mitomycin C can be used. And when you use mitomycin C, it is better that you first inject some viscoelastic like Helon and then inject mitomycin C. So that way it spreads in a uniform manner and the mitomycin C doesn't spurt out of the injection site. So the effect is slightly uniform and tamponaded. So both options are there. For early cases, 5-fluorouracil we use because already we have used mitomycin C. And if you do mitomycin C again, then the side effects come maybe 5-10 years later, then you get a very bad thinning of the bleb. So 5-FU is definitely safer.
Yes. Thank you very much. Anything else, Dr. Pandav, you would like to add on this very interesting talk of Dr. Tanuj?
Yeah, Dr. Tanuj, I think thank you. That was an excellent talk. I think you covered a lot of things and introduced new concepts as well. The only thing about we are on mitomycin C. So I agree with Tanuj and Sunita, the way the MMC is used both like on sponge or through an injection. What sometimes I do is I don't inject it on table, because sometimes injecting on table means that you have already given the mitomycin, and if there's something happens in the post-operative period, you have buttonhole, or if some reason you find the tissue is fragile and you didn't want to use mitomycin, then actually you can't go back. So sometimes I use actually in the post-operative period. So I don't use any antifibrosis on table. You wait for, say, about 3 days on an average, 3 to 5 days, depending on how the wound heals, and then you can give actually in the post-operative period. by injection like 0.01 milligram per ml. Now the advantage is that it actually now it starts acting when you want it to act, because when you give it on table, you're doing a pan, but mitomycin is actually very strong drug, so it gives you the pan inhibition of all the healing processes. You actually want some healing to happen for the first 2 days at least. So we have actually compiled our data. Initially, I was a little conservative and I was using like 7 to 14 days around that time frame. But I think now I have shifted the time frame to somewhere in the 5 to 7 days in the post-operative period. So I have compiled the data. I think hopefully you will see sometime in the journals. But again, this is a new thing, so you can't really recommend for everybody. But our results are this like as good as on table. With the advantage that you can decide whether you want to give MMC or you want to use 5-fluorouracil, or you don't want to go, give any antifibrosis. Sometimes you don't need any antifibrosis. So that option actually remains with you even in the post-operative period. So I think that's something little new, and but otherwise I think what Tanuj has said, that's fantastic. I think most of us are actually using mitomycin C on sponges. Even though I think there are advantages of using as injections as well.
Thank
And
you very much.
one, yeah.
Yes, doctor. Yes, sorry.
Yeah, and the one thing for Tanuj, or just a comment, because are you using that the irrigation, cannula during trabeculectomy, like AC maintainer, or because when I use a few times, if the iris is floppy, it actually goes into your the fistula site, and it creates problem. So I kind of avoid using that. So just maintain your AC as far as possible by injecting through the side port rather than have irrigating cannula. But I think kind of it is recommended in literature, and many people I'm sure use it. But I don't know what Tanuj's experience is in cases where you have a floppy iris, or it's kind of tries to flows into that fistula that we have created.
Yeah, I think this is just an option which is available, and
Mm.
especially where you are expecting a hemorrhage complication like Serge Weber. So other cases, I don't routinely use it, only for specialized cases. But nowadays, in these high risk cases, I prefer to inject some Helon in the AC, because we have had some recently, some pediatric subconjunctival hemorrhages. We had 2, 3 in a row. And that lady scared me. So before entering the AC, we just put some Helon and let that stay in the post-operative period. So you can sleep peacefully the next day.
Dr.
Yeah,
Panda,
sometimes
if
I
I may
leave
add,
alone. Yeah, sometimes I leave alone, but a few times it could lead to high pressure, because we have a tendency to suture like tightly, and then if the Helon is there, then you could have a high pressure. So do you give something in the early post-operative period to compensate for that, or
So
if
usually?
I may add one point with that AC maintainer, I'm sorry to interrupt, is that yes, I would use it when I'm doing trab on a vitrectomized eye. So these eyes, once you do the trab and the internal ostium, they become very soft because the gel vitreous is not there. So having an AC maintainer helps you to suture the scleral flap, to titrate the amount of filtration, and to even suture the conjunctiva. You have a firm globe. So that is the only situation where I would definitely use an AC maintainer. The rest of the cases, as you said, Dr. Pandav, it is more of a hindrance than a help. Sorry.
Yeah.
Thank you.
Thank you.